My name is Charl Els and I'm a clinical professor in the Department of Psychiatry, and I'm appointed as a physician educator in the Division of Preventive Medicine, Department of Medicine at the University of Alberta. This session focuses on the occupational impact of post-traumatic stress disorder, or PTSD, on occupational variables. Thank you to the Workers' Compensation Board of Alberta for making funding available for this project. There are no conflicts of interest to declare, and the opinions expressed in this presentation reflect those of the speaker and not necessarily those of any collaborator or funding agency. Learning objectives. This session provides a brief overview of the features of PTSD, including causation, prevalence, diagnosis, treatment, and prognosis. And it focuses on the occupational impact, specifically on capacity, risk, and tolerance. At the end of this session, participants will be equipped to recognize the occupational relevance of PTSD, especially in safety-sensitive settings, describe the impact on capacity, risk, and tolerance, and broadly outline evidence-based interventions to achieve maximum medical improvement. What is PTSD? Well, PTSD is a mental disorder recognized by the DSM since roughly the early 80s. And this condition follows a life-threatening or terrifying event, either experiencing it or witnessing it. Symptoms that follow include flashbacks, nightmares, severe anxiety, as well as recollections and intrusive thoughts about the event. What causes PTSD? As per the criteria, a stressor ensues that is followed by symptoms. Not all persons exposed to trauma develop PTSD. As a matter of fact, only a minority will develop symptoms. And without minimizing the impact of trauma, the concept of post-traumatic growth applies. Vulnerability factors for the development of PTSD have been identified and include the presence of childhood trauma, select personality traits, inadequate support systems, genetic factors, and recent alcohol intake. Like with most psychiatric conditions, the biopsychosocial model applies, with predisposing, precipitating, and modulating factors, and as said, genetics play a fundamental role in the causation of mental illness. The lifetime risk for PTSD is around 9%, and the one-year prevalence around 3.5%. In some countries, these rates are much lower, and rates of PTSD are higher among military personnel, veterans, others whose vocation increase the risk for traumatic exposure. For example, first responders, law enforcement officers, firefighters, and emergency and medical personnel. The highest rates, up to an estimated 50%, are found among survivors of rape, military combat, and captivity, and ethnically or politically motivated internment and genocide. The diagnosis of PTSD is made by taking a comprehensive history and performing a physical exam to rule out medical problems that may be causing or contributing these symptoms. For the diagnosis of PTSD itself, the physical examination is usually non-contributory, and special investigations are conducted only on merit of positive findings. A psychological evaluation that includes psychological testing, which may assist the diagnosis, is recommended, and the use of rating scales are helpful, for example the PCL5. And it's scales like this one that's also helpful in determining the severity of the condition as well as to monitor the treatment response over time. Using the DSM-5 criteria allows for a diagnosis to be made with reasonable degrees of certainty. PTSD is a clinical diagnosis with no single diagnostic test. The symptoms are evaluated based on the DSM criteria, and PTSD symptoms are generally grouped into 4 different categories: intrusive memories, avoidance, negative changes in thinking, and mood, and changes in physical and emotional reactions. Symptoms can vary over time and vary from one person to the next. Criterion A in the DSM speaks about exposure to an actual or threatened death, serious injury, or sexual violence in one or more of the following ways. 1. Directly experiencing the traumatic event or events. 2. Witnessing in person these events as it occurred to others. 3. Learning that the traumatic event or events occurred to a close family member or a close friend. In cases of actual or threatened death of a family member or a friend, the event or events must have been violent or accidental. And 4thly, experiencing repeated or extreme exposure to adverse details of the traumatic event. For example, first responders collecting human remains or law enforcement officers repeatedly being exposed to the details of childhood abuse. And this criteria does not necessarily apply to exposure through electronic media, television, movies, or pictures, unless such exposure is indeed work-related. The DSM criterion B for the disorder suggests the presence of one or more of the following intrusion symptoms associated with the event. And this usually begins after the traumatic event as per the diagnostic criteria. Recurrent, involuntary, and intrusive distressing memories of the event, recurrent distressing dreams of which the content and or effect of the dream are related to the traumatic event, dissociative reactions, for example, flashbacks, in which the individual feels or acts as if the events were recurring, intense or prolonged psychological distress at exposure to internal or external cues symbolizing some aspect of the actual event. Marked physiological reactions to the internal or external cues that resemble or that symbolize any aspect of these events. Criterion C in the DSM speaks about the persistent avoidance of stimuli associated with the traumatic events, and it begins after the traumatic event, of course, as evidenced by one or more of the following: avoidance or efforts to avoid distressing memories, thoughts, feelings about or closely associated with the event, avoidance of or efforts to avoid external reminders, for example, avoiding people or places or things or conversations, activities, etc., that's closely associated with the traumatic event. Criterion D in the DSM suggests negative alterations in cognitions and mood associated with the event, beginning or worsening after the event, and as evidenced by two or more of the following: inability to remember an important aspect of the event, and that's usually due to dissociative amnesia. Secondly, persistent and exaggerated negative beliefs or expectations about oneself. For example, the individual may start believing the world is no longer safe, things are permanently ruined, or that I'm bad or no one can be trusted. Thirdly, persistent, distorted cognitions about the cause or consequences of the event that lead the individual to blame him or herself or others. Persistent negative emotional state, for example, an ongoing state of shame, guilt, fear, horror, anger. This marked diminished interest or participation in significant activities. Feelings of detachment or estrangement from others. Persistent inability to experience positive emotions. In other words, there's a loss of satisfaction in life, or that sense of experiencing loving feelings may be lost. Marked alterations in arousal and reactivity associated with the event, beginning after the event, characterized by two or more of the following: irritable behavior and anger outbursts, sometimes with little or no provocation, typically expressed as verbal or physical aggression to people and others. Reckless or self-destructive behavior, hypervigilance, exaggerated startle response, problems with concentration, sleep disturbance, insomnia, or simply having difficulty falling asleep, staying asleep, or even maintaining restorative sleep. Duration of the disturbance as per criteria is for more than 1 month, and this typically has to result in clinically significant distress or impairment in social, occupational, or other important areas of functioning in order to meet the criteria. Further, the disturbance is not attributable to the physiological effects of a substance, be it medication, alcohol, street drugs. The criteria suggest that the symptoms of PTSD start after the traumatic event occurred, but it's important to note that sometimes these symptoms may not appear until years after, in some cases up to 30 years following the event. Risk capacity and tolerance determinations. Unless cognitive symptoms are severe, capacity is usually unaffected by PTSD. Occupational risk, however, may be impacted, especially in safety-sensitive settings, as a result of the lack of predictability of mental functioning, impaired attention, and other cognitive symptoms, anger outbursts, road rage, psychomotor agitation, as well as a lack of emotional regulation. Symptoms may erode occupational tolerance, which often improve with treatment. Remission for 3 months or longer is usually required for a return to work in a safety-sensitive context, while for acute stress disorder, after a period of 1 month of full remission, return to safety-sensitive duties may be allowable. Treatment consists of both psychotherapy and pharmacotherapy, typically in combination. Psychotherapy modalities that are proven to help are cognitive therapies, example, cognitive processing therapy or CPT, exposure therapies like progressive exposure therapy, eye movement desensitization and reprocessing or EMDR. There's also somatic experiencing therapy that's proven to be effective. A number of different medications can help improve symptoms of PTSD, and these include the antidepressants like the SSRIs and the SNRIs, anti-anxiety medications, and others. The compound prazosin has been used to suppress symptoms of nightmares in some individuals with PTSD. In situations where the original trauma was occupational related, it's important to avoid re-traumatization when back at work. Maximum medical improvement is usually reached within months. The prognosis varies widely, and if untreated, about 1/3 will recover completely, with about 40% having mild symptoms, 20% having moderate symptoms, and about 10% remaining unchanged or deteriorating. If treated, the prognosis is optimistic, and good prognostic signs are the rapid onset of symptoms following trauma, as well as short duration of symptoms. Post-traumatic stress disorder develops in only a minority of people exposed to trauma, and the majority of people will actually undergo post-traumatic growth. PTSD is potentially disabling and adversely impacts occupational risk, especially in safety-sensitive settings. PTSD is highly treatable, and with remission of symptoms, persons can usually return to work, but caution should be taken not to re-traumatize individuals in cases where the original trauma was work-related. We've included a list of references which may be of help. Thank you, and we look forward to your ongoing feedback and comments. Please help us identify further topics for future discussion. Thank you.